Good evening and welcome to Trio Philadelphia's June 28th, 2022 meeting. I'm your host tonight, Bill Soloway, the president of Transplant Recipient International Organization, Philadelphia chapter. We have a great topic tonight that we've been wanting to discuss for some time. We have a guest with us tonight who is the lead surgical physician assistant, of the Penn Transplant Institute Abdominal Transplant team. She has a Bachelor of Science from Towson University, where she received the Dean's Recognition Award, and a Master in Anatomy from University of Maryland in Baltimore. She graduated from the Hahnemann Physician Assistant Program at Drexel University and obtained a Master's in Science Health, and has been recognized as a distinguished alumni. Boy, it just keeps coming. Ready? She participated in procurement of the first bilateral hand transplant in Philadelphia, as well as the first uterine transplant in the Philadelphia area. So she continues to assist in the training of transplant fellows on procurements consisting of over 1,700 liver and kidney procurements for transplant, as well as over 100 heart and lung procurements for research. She's responsible for the evaluation of livers for donation during procurement. Georgine Smith has been awarded the Dean's Recognition Award from Towson University, where she has also given a commencement speech. She continues to provide numerous educational lectures and presentations for her institution, ASTS, AASLD, and elementary schools. She has participated in research which is published in the American Journal of Transplantation. She's also a member of the American Society of Transplant Surgeons and has served as inaugural associate counselor liaison member of the Advanced Transplant Provider Committee, former chairperson of the Advanced Transplant Provider Committee, and she's a member of America's Pancreato, boy, say that 10 times fast, Bilateral Association. So you can tell us more about that, Georgine, in a minute. And she's currently a member of ASTS Foundation Board and ASTS Fellows Committee. So if that isn't enough, and I'm sure she can go on and on and on. So I want you to join me in welcoming Georgine Smith tonight, our featured presentation. Georgine.
Thank you very much, Bill, for that introduction. I went on.
Yeah, what a mouthful.
Hepatobiliary, that was HPB, Hepatobiliary Conference. So I'm really, thankful to have this opportunity to speak with this, amazing organization. It's really beautiful, to see all these, all of you guys and the people that we're recording for as well, because it means a lot. Everybody on these teams works exceedingly hard. You can't even put it in words how hard everybody works. And the best thing is, to see people when they're doing so well. So it's, this is quite an organization, and I'm really proud to have an opportunity to speak to you about what we do. So I'll get going. I'm going to share my screen and hope that's always like a stickler. And I apologize for the format a little bit here. But today I'm going to be talking about the procurement side of transplant. And I as Bill had mentioned, I'm with the abdominal transplant team. And so our job is to go out, and whomever procures the liver is the one who also procures the kidneys. But I've been in the OR a number of times when they're procuring heart and lungs, and I'll try to touch on that a little bit, but I certainly am not the expert with that. So I don't know if you guys have heard about, the OPO, the Organ Procurement Organization, but I wanted to start off with that because that's, part of where, the ball gets rolling. And certainly, you go to your hospital and you're listed for transplant. And when an organ becomes available, it's the OPO, the Organ Procurement Organizations, that get the ball rolling. So they're not-for-profit organizations. They're responsible for recovering the organs from deceased, donors for transplant in the United States. There's 57 OPOs, and they're mandated by federal law to perform life-saving mission in the donation service area. I don't know if you ever heard that. Often they'll talk about the DSA, but these are the areas that are assigned to them. So there's different regions that exist throughout the United States, and within these regions, they have OPOs based upon the number of the population, as well as transplant institutes that are within that region. So they're responsible, for taking care of every donor in their specific area, even those, and some of those areas don't have a lot of donors. So even if you have 1 or 2 donors, the OPOs are still responsible for that area. They're the front line of the procurement. They work directly with the decedent's family during the emotional discussion about the potential donation of the gift of life. So the OPOs, they have this group of individuals that are they're usually ICU trained nurses. They may be some EMT people, and they're the ones that approach the family. So what happens is when the patient is in the ICU and they're appearing brain dead, it is a national law that that hospital must contact the organ procurement organization for that organization to come in and assess the donor, for potential donation. And when that person comes in, they're doing the paperwork and looking at the patient's chart to see if this patient would be a suitable donor and for what organs, but also they're the people that go to the families and ask if the families want to donate. So they have a very, very important job, and they're with the donors for about 24 hours while the organs are being allocated, while they're keeping managing the donor until we eventually go to the OR. So they spend a lot of time with the donor's family and with the donors. So they get consent for the organ donation. They enter the medical data, such as the donor's blood type, the body size, location of the donor hospital. All that goes into UNET, which is the UNOS secure web-based transplant, linking all organ procurement organizations and transplant hospitals. And that initiates the matching of the potential recipients. So when you talk about size, a blood type, okay, we can't get around blood type. There has to be a compatible blood type. And the same thing with size. I mean, the organs have to be a suitable size for the potential recipients. But once that matching is done, these OPOs, the organ procurement organizations, they'll call the hospital that has the potential recipient. They call all day and all night, and they're going to offer this organ to the attending surgeons. And so they'll give the data, the height, the weight, the mechanism of the injury, some of the labs, and then the surgeons will say yes or no. So this is just a word cloud just to show you just how many OPOs there are out there. In the Philadelphia area, it's the Gift of Life donor program. Pittsburgh has the Center for Organ Recovery and Donation. New Jersey's Sharing Network, and they're all over the United States. So when you talk about a patient and how do they get to be a donor, and there's criteria. We can't do this type of surgery on someone who has not been declared brain dead. So there's brain death and cardiac death. And brain death, I would say probably 95% of the donors are brain deaths. I'm just going to focus on brain death. It's a severe brain injury from trauma. That trauma could be a gunshot wound. It could be a motorcycle accident, cerebral vascular accident, a stroke, anoxic event where there's been a lack of oxygen to the brain. So that could include death by suicide. It could include an overdose. It could include asthma. But when someone has unfortunately sustained that type of injury where basically the brain is turned off, that's when it's a referral to the OPO. And so they have a clinical exam, and they have to do 2 exams to declare the patient brain dead. So one of them is an apnea exam. Basically, I don't know if you guys know, when the doctor sticks a tongue depressor and you really want to gag, but they're looking for that reflex, which is one of the rudimentary reflexes that is a strong indicator for someone who has brain death. And patients that have brain death will not have an apnea exam. And then also there's a nuclear flow test, which they use some special instruments there, not instruments, but necessarily a special test to check to see if there's blood flowing to the brain. And so once you have had 2 exams, I believe those exams have to be 4 hours apart from 2 different providers. That's when the person is declared brain dead. So this is what the transplant coordinators do. They have to make sure this donor is pristinely stable. So if you can imagine someone who's sustained a brain injury, if you do nothing, this person will pass. But they want to make sure that they're able to maintain this person, this exceedingly generous donor, until we're able to allocate organs and get to the OR. If it's a person who's very unstable, not everybody who sustains this type of injury is stable enough to make it to donation. So they're drawing labs, looking for hemoglobin and blood gases. That's to see how well the organs are oxygenated. This patient is certainly intubated. They have a breathing tube in their mouth, but you want to make sure the organs are getting an adequate supply of oxygen. Fluid resuscitation, plenty of times as someone is brain dead, and if you would proceed and just allow the person to pass, the blood pressure is going to go down. So plenty of times they'll use fluids, just adding an IV bag of fluid to help keep the blood pressure up. But as you're adding fluids, you don't want to wash out the electrolytes. And electrolytes are something like your calcium, potassium, sodium, chlorine, all these electrolytes that the body needs to work properly. So you don't want to give too much fluid and to wash that out. They'll give vasopressin, as this says here, that will slow the release of urine, another way to keep some electrolytes with the body. And then right before you go to the OR, then you start to diurese the patient. And that's just to get this fluid off, because there's a lot of fluid. And when we're doing our procedure for the donation, there can be an awful lot of fluid. So this is what it looks like when we're going on donors. It's planes, no trains, thank goodness, but automobiles. So we'll fly with jets. Now that they've changed the area that we serve. So before, the regional area was smaller. Now the regional area that we serve is 500 nautical miles from the donor hospital. So we're going everywhere. Last week I was in North Carolina twice. I went to North Carolina, then I went to Allentown, then I went back to North Carolina this was 3 different donors. I've been to Michigan, I've been to Phoenix, I've been to Tampa, Florida, Buffalo, New York, all over. What I'd really like to show you with these pictures is how uncomfortable it is in the helicopters. This gentleman here, his knees are almost to his chest. That's the helicopter. And if you hear, I'm sitting next to Dr. Abraham Shaquette in a helicopter, and it's really close. Like, you're sitting like this. The helicopters, they're cold. It's cold in there. There's not a lot of heat. So if it's a cold day, you're going to be cold, and they'll say bring blankets and whatnot. It's kind of cool when you're going up and going down in a helicopter, like this picture shows here, beautiful view of Philadelphia. But other than that, it's transportation. And the main thing when we're going on donors, because they typically happen in the deep dark of night, is sleep. So they will call me anytime, but usually they call late at night, and we get picked up at the, very, very early in the morning to start our procedure, maybe at 2, 3, or 4 in the morning. So this picture shows this is exactly how we do it. If you'll notice, these are some of our fellows. And if the big part about this picture is it's total daylight, but the fellows are out. When we get in the vehicle, it is prime for us to get sleep. So we'll sleep on our way to the donor hospital. From the abdominal team, we travel primarily by vehicle. Anything more than, I know we've driven as far as like 2.5 or 3 hours, because we will drive to like DC and to Virginia, like Northern Virginia. But after that, then we start flying. But I like it when we drive, because it's longer time that you get a chance to sleep. So you imagine you can sleep going, because it's 11 o'clock at night, you can get some rest, and then coming back, you can still sleep. So that's really, this is what it looks like. So when we get into the OR, when we get to the donor hospital, they take us to the emergency room. And from the emergency room, security escorts us to the OR, and then we let the transplant coordinator that's with the patient in the ICU know that we're there, and they bring the patient down to the operating room. We prep and drape, and we get ready to start a procedure. And before every procedure, regardless of the OPO, they always have a moment of honor. And this is an example of the moment of honor for the gift of life. So today we come together to care for our patient and all those who will benefit from this gift of life. For all the parents, children, family, and friends who are touched by what we do here today, may we remember the new hopes and dreams that begin with this gift of this one person. May we take a moment now in silence to honor the life of our patient. And so that's read before every case, and every OPO has a different poem that they read. Some OPOs, they ask the family to write something, which is really nice to hear something about the person, because these donors come from a sudden injury. This isn't a lengthy illness that this person has had. It may be a chronic illness like asthma, but the death just happened. A car accident, an overdose, someone fell off of a ladder. So these are things that the family has suffered, a very, very shocking death. So the donors are exceedingly generous. And so this is what the surgery looks like. Our incision, it goes from the sternal notch to the pubis. So if you could imagine like that little notch, like, just like at the very, very tippy top of your chest right here, that's where we start. And it goes down maybe like 5 inches below your belly button. This is for the abdominal team. I've never been on a donor where it was just heart and lungs only. So, and we have our Balfour retractor, that's a piece of metal that's used to open up the abdomen so we can have, great access to the organs. And we do a sternotomy where we're going to open up the chest. So imagine in front of your chest, there's your breastbone, the sternum that's holding your ribs, and we need that to open because we need to have access to the heart. So in the picture over here, these sort of pink things, that's lung. Right under here is liver, and the rest are your small intestines. And this other picture, we were able to lift up the liver so you can see what a liver may look like. This liver has a bunch of lumps on it, which is normal. It could look like that, but this is a very healthy liver that we used for donation. So I just have some more pictures. This is what it actually looks like when we have the chest open. You can see the heart sitting here. Can't see the lungs because they're still tucked back. This white structure here, this is the stomach, actually. And you can't see the liver because it's covered by the intestines. This down here, that could be the bladder. And so this is just another example. This picture was a video, but I couldn't get it to come over as a video with the beating heart. But the darker organ here, that is the liver. And the kidneys are, the kidneys actually kind of sit on your back. So they are really covered by not only your intestine, but they're also covered by some fat. So what do we do? After we do our dissection and we're ready to cross clamp, that's like the big procedure that happens throughout the case. So what we have to do is, in order to transport these organs, and the heart and lung does the same, you have to perfuse them with a preservative solution. And in order to do that, you have to put cannulas in. So when we talk about cannulation, we put them in the inferior mesenteric vein and the aorta for the abdominal team. Not quite sure where they put it in for the chest team. And there's a certain area on the aorta that's in the belly that we have to put an actual clamp over to close that off. And so that's the big cross clamp time. So that's the time when the organ no longer is receiving warm blood, but it's receiving cold solution as a preservative. And the warm blood gets exsanguinated, sucked out of the patient. So I'm not sure if you can notice these little plastic tubes here. These are our cannulas that are administering this cold preservative solution. Ice. I mean, we just take ice and just put it in the body, and it's sterile ice, of course. It's really, really, really cold. And then we wait for all of the preservative solution. We put 6 liters of solution in the organs in the abdominal side. And so so you just have to wait for all that solution. So that takes maybe about 5 minutes. And then once all the organs have their solution in, it's time for us to do our dissection and to remove them. The heart comes out first. So they'll take the heart out, and that doesn't take very long. Then the lungs come out next, and that sometimes can take a little bit more time. And then the liver comes out, the pancreas comes out if they're doing a pancreas, the small and bowel comes out if they're doing a small bowel. And then the kidneys come out last. If they're doing a uterus, the uterus would come out after the kidneys come out. And so this is what it looks like after it's out. So this darker organ here, that's the liver. And as I mentioned, the kidneys, really just a blob of fat. This long structure here, that's the ureter of the kidney. Living donation for livers. I'm not sure if you guys are familiar, but you can donate a portion of your liver to someone. The recipient of the liver, their entire liver comes out, and they'll receive half of a liver. So the donor will still have a half, and the recipient will receive a half. And both of those halves will grow to a suitable size to maintain life in both the donor and recipient. So I just wanted to show a diagram of how we split the livers. This right lobe is for an adult. That's a pretty good size piece of liver. That would be taking this section of the liver here. The left lobe, again, you can use the left lobe, for, it says a small teenager, but we've used it for an adult here. But this left lateral segment, that's a small segment that would be for a child, an infant actually. And this MRI here is showing just how they look at the volumes, like, so they know where they can split the liver, because you have to know, well, how much can we take? But you don't want to take too much because the donor still has to keep enough liver for them to stay alive, but we need to take enough so the recipient will be able to be alive. And so we do at HUP about 12 to 18 living liver donations a year. And so these are my final pictures. This shows some of the pediatric organs. This is a baby liver. And this over here with the white gloves is a portion of a liver, a right lobe. Again, the same right lobe. And that's kind of like what we look like when we're getting on the plane to go for one of our uterus donors. So those are my pictures. Those are my diagrams. Of course, I'll take all of your questions, but I'm very, very protective of the donors. Again, these are people that are exceedingly generous. They've given so much of themselves, and one donor can help so many people, because outside of just, the internal organs, there's also corneas and there's skin and there's bone, and they'll use heart valves, for actual donations. So donors are very, very, very generous. So again, I'd like to thank all the members of TRIO for allowing me an opportunity to share with you what it's like on my end. Again, I'm happy to take any questions that you have, and some things aren't clear, please speak up, because I'm happy to clarify it for you.
Yeah, so I can start off because I have a lot of questions.
All right, I'll stop sharing.
and that is so cool. Yeah, if you want to shut that down and bring us all together. Perfect.
Right, great.
So how many teams, Georgine, get dispatched to a donor?
Oh gosh, too many sometimes for us. It's tough because if you can imagine, so if you look at your body, so from top of your shoulders to your hips, imagine you have 4 people standing beside you. So below the diaphragm, that's the abdominal team. Above the diaphragm, that's the chest team. And the chest team could be made up of 2 surgeons for the heart, 2 surgeons for the lung. Then there's 2 surgeons for liver and kidneys. And then there's a separate surgeon for pancreas and a separate surgeon for uterus. If that goes, it can be crowded.
So do you need to have pointy elbows?
No, you're like tucked in like this. We'll all start at the same time. But the heart team, they're a little extra, so they kind of lean a little too much. So sometimes, we'll just give them their space because they don't have that long of a dissection to do. Let them do their dissection, and we'll come in and finish our dissection as well. But we all start at the same time.
Another question I have is I constantly get pictures from friends who see the Gift of Life Suburban or whatever that has Illinois plates on it. And they're like going, are they getting an organ? So what is exactly their involvement, if at any, with procurement?
So initially when I first started this, and I've been doing it for about 15 years, we had a limo that would drive us around, and that was great because you can lay flat in a limo and sleep, and limos are quiet. But we tore the limos up because it's a lot of work on a limo. So now there's a service called NORA. And I don't know what NORA stands for, National Organ Recovery Association. I'm not sure, but it's a service of drivers. And these drivers are former police officers and firefighters typically. So they're used to driving and being up at odd hours. And that service is out of Illinois.
Oh, okay.
So that's why it has the Illinois license plates. But they're serving Milwaukee, Jersey, Philadelphia, and obviously they want to be national. So yeah.
Okay. Yeah, because it has Gift of Life on it, and periodically I'll see one and I'm just going, I wonder what's going on with that, right?
Yeah, Gift of Life has their own fleet of these vehicles, but it's not Gift of Life people that are driving them. It's actually these NORA drivers.
Okay.
Yeah.
So tell us the coolest procurement story that you can think of. Is there any one particular instance that sticks out? Something funny that happened, something that was out of the ordinary?
There's usually not too much funny things that happen. I can't think, like some of the things that happen increase the degree of difficulty. It can, we had a donor who was 21 years old, motorcycle accident. So these are pristine organs, and he's donating heart and liver, kidneys. And during the procedure, early on in the procedure, the donor goes into cardiac arrest.
Wow.
So then the heart team is like, okay, we're out. And so we're like, well, you can't leave. Yeah, we're out, we're leaving. Well, who's going to run the code? Because we need someone to run the code because we're not leaving.
Right.
And we need this to keep going. I know you're not going to use this heart, but they're like, well, no, we're not. Then they left. They just left us.
Wow.
So anesthesia has to run the code. So the CRNA calls the anesthesiologist and they start pumping fluids. So in the meantime, I say to my fellow, I'm like, look, we've got to do this like a DCD, meaning which is a very quick procedure where you can remove the organs in 15 minutes. And this was a new fellow and he wasn't comfortable with that. And so I'm like, well, we don't have any blood pressure. Like, we've got to go. We got to get out of here. He's like, I have to do the long surgery. So I was like, all right, well, then we're just going to keep moving. So while I was assisting him with one of my hands, my other hand was doing chest compressions.
Wow.
Because we've got to keep blood
circulating.
Going. Yeah. Ultimately, anesthesia was able to help us, thank goodness, and get some drugs on board. So the heart was pumping on its own and we were able to complete the procedure and use the organs. But I knew I could not come home without this 21-year-old liver. That's not going to work. They're just not going to understand that. There's no way. So there's another time in the OR where the cardiac surgeon was sick. It was a fellow and he was sick and he looked like your shirt, Bill. He was sick.
Wow.
And we're like, so he calls his attending, hey, look, I'm not feeling well. And the attending's like, pull your skirt up and bring me back the heart, and hung up on him.
Wow.
And so we're like, oh boy. So the fellow, he took a couple bags of fluid. He sat there and they gave him an IV of fluid and he started feeling better. And we did the procedure and brought the organs back.
Wow.
So you go through above and beyond, like you do absolutely everything you can for your recipient.
Sure. So I'm going to spread around the wealth here because I know everybody else probably has questions and I don't want to take up all the time.
Sure.
Jim, what do you have for Georgine?
I've been trying to think of something and I really can't.
Jim's like,
Georgine, in the heart, and I know you said that's not your main field, but the image you have of taking a whole heart out and putting a whole heart in, my understanding is that's not what normally happens. That what goes in the recipient, they leave the back of the heart in, and then they take the donor heart and match it up to that. It's just easier to connect, doing the suturing around the back to the front as opposed to the arteries and veins. Is that, am I correct? Or is, and I'm sure they do either one. My understanding is they did mine different. So I may be a whole replacement. I've heard the term, I don't remember it right this minute, but am I describing something that's a little bit understanding as opposed to what we normally think of? It's just a heart going in and coming out like a
It's plumbing. It's all plumbing. It's all, and I really can't speak on their procedure because I've never seen a heart transplant.
Okay.
But I know they have some big vessels, you know, they've got some big vessels that they have to hook up. And there must be a reason why they keep the back of the native heart, the heart you're born with, in regards to how they do their anastomosis. But I really can't speak on that because I've never seen them do it. But when they bring the heart back, it's the entire heart. They don't bring the heart back minus the back.
Right.
It's the entire heart. So there may be some sort of piggyback routine that they're doing. But I couldn't say. I apologize. I just don't know.
The other area, and it's fairly new, so I'm not sure if you have any experience with it, but between lungs and now I'm hearing about livers, the in vivo type of preservation where they're putting the organ once it's recovered on pumps before it comes into the donor side or the recipient side. Can you speak to that at all? I know I heard about someplace out there, and then I checked with Gift of Life, and they said, "Oh yeah, we do that all the time. We're part of the trial." So can you talk a little bit to that? It's a major innovation, right?
Yeah, it really is. So that it's designed to, how do I want to say this? It's designed to bring marginal organs up to speed, shall we say? Some organs that you may like, probably will give us, give the patient a really rough course, or an organ that's not usable. So that's what it's designed for. So they're doing normoperfusion, which is warm blood being perfused through the organs and until they implant them. And I was just in the OR, where were we? Was it Michigan? I don't know. I can't remember where we were, but it was kind of annoying because we were waiting for the heart team, and then they finally showed up, and they're like, "Okay, we'll take the heart." And they took the heart, and then they put it on the pump. So the pump machine, it's not that big because the heart's not that big, but the heart, when I glanced over at it, the heart was pumping and beating, and it's, having blood going through it. So they must hook up some sort of electricity to get that heart going, because when it came out of the body, it certainly wasn't pumping, but when I looked over at it, it was pumping blood. So, and they do this. Yeah, they do the same with the lungs.
Some are supported by batteries for travel by plane, for example. But the other big benefit, of course, is extending the out-of-body time frame as opposed to the limitations with the heart. It's what, 5 hours, 6 hours?
Yeah. So
24 hours, according to things I'm hearing from Europe.
Right. So if you think about, if someone's in Iowa and the perfect heart for them is in Rhode Island, you can't make it. You just can't make it. But with these machines, you could make it.
Right.
Yeah. And so, yes, so that's new technology. I don't think any of it has gone to the FDA as of yet, but it absolutely is happening.
Well, I know the kidneys had done it a long time. In fact, Howard tells a story early on in his career of taking a kidney over to Rome, I think it was, that wasn't getting used here, and he wasn't about to let that go. And so he ended up taking it over to Europe. Yeah.
Kidneys have been on the pump for a long time. Yeah. You're right. Yeah.
You're muted.
Thank you. Sorry. We have Elizabeth, who is a liver recipient. Elizabeth, do you have any liver related questions? You're muted.
I'm muted too. Okay. I found that absolutely fascinating. Yes, I am a liver recipient, and I had my liver transplant in Pittsburgh in 1992.
Okay.
So
congratulations.
I don't know how much, thank you. I don't know how much has changed since then.
How long were you in the hospital?
How long? Oh, I was in the hospital for like 5 weeks before the transplant, and about 4 weeks after, and then I left for a little bit, and then I had to come back for another 3 because I had some rejections that required what is it? OKT3?
OTK.
to kill the T cells?
Yeah.
I did have a question, but you don't know this one probably, whether the T cells grow back after, they.
I don't know. I mean, there's got to be some in your body, but as far as to that level, that I really don't know. I'm not an immunologist.
Yeah.
But congratulations, because people ask me all the time. I do the evaluations of the patients for the liver transplants in clinic, and they'll say, "Well, how long, is this going to last?" And I had a friend of mine from high school. Her mom was transplanted and had her liver for 20 years and died of something else. So now I can say, yeah.
I mean, I think it obviously depends on what the cause of your liver failure was. In my case, it was cryptogenic cirrhosis. The only thing they could tell me was I probably had a virus when I was pregnant with my second daughter, because my liver failed right after.
Oh, wow.
So yeah, well, thank God I had a good husband who figured out how to take care of a 4-year-old and a newborn. It's pretty amazing.
Well, Georgine, now you can add your stories. You've just come back and talked to a 30+ years out liver.
Yes. It's I'm telling you, people ask that all the time. The time.
Of course.
Yeah.
Mm-hmm.
Georgine, what's your favorite mode of transportation for a procurement?
Limousine, the limo, man.
The limo, because she can lie flat.
A nice long ride in the limo.
I remember being in the hospital and we heard helicopters flying overhead, and we always thought, oh, maybe that's my liver, but
livers rarely come from helicopter, just because, our team, we like to drive just because it's safer. So we're doing a, drive, like I said, pretty far, but yeah, I guess we certainly have had jets. I mean, we went to Phoenix for a child, and that was a little tough because of time. You have like 8 hours of cold time. That's when the warm blood is no longer in the liver, just talking strictly liver. That's optimal. Anything outside of, 8 hours, it gets worse, pretty quickly. So it's kind of hard to fly all the way to Phoenix, stop for gas in Kansas City, do a surgery, and come back within 8 hours and get it into the child in 8 hours. Of course, the children are more resilient, and it was a pediatric liver to a pediatric patient. So that helps out, if you need a couple more hours of time.
Georgine, when you're getting one that far out, obviously it's been offered locally first and others have turned it down. So are you looking at something that's less than optimal, but you got such a sick patient at the other end, you're going to go the extra mile?
Not really. For pediatrics, you go everywhere.
Okay.
Yeah. But we still will get offered, a very good, good quality liver and go very far, because sometimes in the local area, you don't have a compatible blood type, you don't have a compatible size, and the offer goes further out. Mm-hmm.
Does anybody else have a question for Georgine? Steve, I know you're thinking of something good.
Look at Steve.
John?
No questions, but just a great presentation. Thank you, Georgine.
Oh, it's really my pleasure. Like I said, it's just so beautiful to see everybody. It means a lot. Really means a lot.
Yeah, I have a question.
Okay.
Go ahead, Susan.
I have a question. And this is more on the transplant in as opposed to the procurement side.
Mm-hmm.
I'm a kidney and pancreas transplant, and I'm out 24 years from Penn. And I know some centers remove the appendix if you're getting a kidney pancreas.
Mm-hmm.
Penn at the time didn't. I don't know whether they do that now. The only reason I'm curious is my one major problem post-transplant was I had a burst appendix, and it took them 4 days, and they just opened exploratory surgery to find the appendix because it was hiding behind the transplanted pancreas. Yeah. So,
Like we don't have enough problems already,
Yeah.
you know?
is it now normal is it now normal to remove the appendix?
I don't know, I'll have to ask them. And congratulations, on your transplant. That is just so beautiful. I really don't know. I know with the livers, they remove the gallbladder. That's like standard, but I'm not sure about the appendix. But for the reason that you just outlined, you don't want to have to, to go back in for anything. Just want to sew it up and done.
Yeah, this was like 10 years, or I'd have to do the math. It was like maybe 15 years after my transplant. It was kind of one had nothing to do with the other.
Yeah. Did Dr. Naji do your surgery?
Yes.
Yeah, Dr.
Naji did my, it's awful. I forget. It was Naji and
Jim Markman? Dr. Markman?
Not Jim Markman. He was around then. No, he's down in Virginia now.
Oh, I don't know then. Yeah, I don't know.
And I'm just drawing a blank. I just saw him on Facebook today
Okay.
too. Also,
Yeah, but Dr. Naji's still there. He's not in the OR anymore, but he's still at the hospital. He does a lot of research. He's, as far as the hospital, he has been awarded the most money for research, like millions. He's doing amazing research.
Susan?
Yeah.
Susan? Was it Ken Brayman?
Yes, Ken Brayman.
Okay.
That's exactly it. Yeah, Naji, I think, did the pancreas and Brayman did the kidney.
Gotcha. Well,
So, Gina,
congratulations.
I had a question for you. Have you ever met any of the patients that you procured organs for?
Yeah, I do meet them. Not as much though. They wouldn't know me.
Right. But like check on someone to see how they're doing, or
You know what? I check on them through the people that are taking care of them on the floor. Sometimes I get an opportunity to go up in their room and see them, but not often. I used to do post-transplant clinic where I would see patients, but with the way that the team is set up now, I don't get that opportunity. But you're right. I mean, it's better than a paycheck to see someone, who's doing well. It really is. We do see them before we go out for the procurement. We'll meet the patients, while they're in the hospital, admitted, waiting for the transplant, just to meet them and see that, as far as size, and to go over a couple, small things before we go out, to procure the organs.
and do you ever get an opportunity to meet the donor's family, or?
Never. That's verboten. That is something I don't ever want to do. Because again, these are people that have suffered a great loss, instantaneous.
Sure.
And I don't want to be the face that they will remember, procured their loved one's organs. So it's kept super duper secret. What they do now is have an honor walk. A lot of hospitals do that. When the donor's leaving the ICU on the way to the OR, they overhead announce an honor walk and tell people where to line the halls, and bring the donor down to the OR that way. There's been some instances where family escorts their loved one to the OR. Some of the DCD donors, they're not the brain dead, but that's donation after cardiac death, a different procedure. The family will come and sit with their loved one in the OR while their loved one, makes their final journey after life support has been removed. And during that time, we are in the OR, but we're waiting in the sterile core, and we don't enter the OR until the family leaves. So no, we have nothing to do with the family.
Bill, the other thing that I think a reminder, especially we're talking about people who are many years out, is that opportunity to go back and show these medical professionals that were part of our transplant what life has been like many, many years later. I had the good fortune just last week, my cardiologist who helped me before I was listed for transplant sent an email that she's retiring. And so I said, well, how about we do lunch? And I'd been to their office about 5 years ago just to say thank you. It was out over 20 years at that point, and to give them that encouragement. So I tried to find some gift I could give her and her assistant who met me for lunch. And the best I came up with was a series of pictures of life coming home from the hospital out to today, which is 28 years later. And I was able to share that with the cardiologist who kept me alive in the hospital for the transplant. It turns out he went into research locally. And so my 25th anniversary, I looked him up and ended up having lunch in he's a CEO of the research company now. And so I had lunch with him in his office, and I was able to bring him pictures from this cardiologist, who was the one who, when I couldn't get an appointment down there for 3 months, she went down and talked to this cardiologist and gave him the story. And she said, he's not going to make it 3 months. And so they took me in then. And of course, I'm constantly in touch with the surgeon, Mike Acker, who did my heart. And so it's nice to be able to connect with all three of them. And most recently, at education we're doing for nurses, one of the nurses said, Mr. Gleason, I took care of you when you were in the transplant. I said, really? And I had no idea who she was, of course, but we had a great opportunity to take a picture together. And so Elizabeth, Susan, and others who are out these many years, what an opportunity it is sometimes to go back. And I know Elizabeth goes back to Pittsburgh, of all places, to take her thank you.
No, you know what, I have to be honest with you. The last time I was there, I think was my 25th. None of the people who were there when I was there are there, because, you know, Pittsburgh was a teaching, well, I mean, Penn is too, but I think at the time I was transplanted, they had a lot of doctors who were trained, and then they went out all over the country. And, you know, like John Fung was my transplant surgeon. He's in Chicago. He was in Pittsburgh, then he was in Ohio, and now he's in Chicago. And I tried to track down some people, like I let them know I was coming and all. It was very disappointing on my part, like, you know, and I don't know, I may go to Chicago for my 30th celebration to see Fong, as opposed to trying to go through, because I just didn't connect. And I had a doctor who didn't know anything and hadn't read my records and asked me to tell my story. It was like, okay, you have my records, I have to go through this whole thing. But, you know.
But that is true. That is true. Like, you know, teams do change. I mean, our team has changed, you know, an awful lot. But one thing, you know, you always can do, and my girlfriend, you know, whose family, you know, fortunately had their mom with them for an extra 20 years. When her mom passed, she continued to write the donor family and gave that last letter to the donor family saying what life, you know, 20 more years of life, you know, thanks to your gift. So you can always, you know, and encourage others to write letters to the donor families, because they really hang on to those letters, because they don't know, you know, the gift of life will tell them what organs were used, but they don't know who they went to. I mean, you know, it is very confidential for a lot of reasons, but you can always thank that donor family.
And Georgine, go ahead, Sue.
I just wanted to tell you that my nephew died just a few weeks ago up in the Poconos, and he was a donor. And I believe he was brought down to Penn to secure the organs that they were able to use. I don't think it was so much organs, but tissue. I think the organs weren't viable for whatever reason. And they used his eyes, and his wife did get a notification or a letter from Gift of Life that his eyes had been used in 2 patients. So
Yeah.
yes, that's our family in more ways than one. So
Yes.
I didn't hear that. So I had a question about the donor families, because I wrote letters for the first 5 years or 6 years, I don't remember, to CORE out in Pittsburgh. And maybe it was because of the time, you know, when it was. They wrote me a letter after like 5 years and said, your donor family, your donor's widow has moved out of the area. We have no tracking for her. So you might, I mean, basically they said you might as well stop writing.
Yeah, yeah.
And so I haven't written letters since then. Now I would love to connect with someone, but I haven't, and I don't know whether it's even worth it at this point.
Yeah, that would be a lot of digging, you know, to find people, because that was, you know, obviously, you know, one terrible incident in their life, but they have no connection to CORE or to keep in touch with CORE. So that would be very difficult. Very difficult.
Georgine, would it be something that you could use if Elizabeth could write a letter of thanks to the donor family that you could then use copies of with patients like you described who ask about that and say, you know, I have this 30 out liver patient that just shared a letter. She can't reach her donor family, but she shares it with us. Offer that letter to them or just read it to them, one way or the other, by way of a very emotional way of sharing an answer to their question.
That is a great idea. And also there's a lot of support groups for people who are, pre-transplant, what is it going to be like? So you're absolutely correct. Yeah, your words are always very valuable, very valuable.
And Georgine, I just wanted to say on behalf of all of us who are life-saving solid organ transplant recipients, thank you.
Thank you.
Because without you procuring our organs, right, a very vital step in our journey, right? So since you don't really get to see people after the fact so much, all of us just want to reach out to you now and say thank you for what you do. All the
Everybody go off on mute and say thank you.
Yeah.
It really is my pleasure, Bill.
All those long hours, all those crazy hours that you work, right? You could get paged right now.
Yeah.
So
yeah,
thank you.
It really is my pleasure. I never have a bad day at work. My job is always exciting and I really love it. And like I say, this is, better than a paycheck to actually see the people that you have the privilege to help. So, it's fantastic to see everybody, and doing so well because, and the team, it really, Dr. Althoff will always say it's a team sport and, none of your surgeons do it without the team. And it's the people bringing your food trays, after you've been transplanted, and the person who cleans your room, and physical therapy that helps you get up and around, and the valet guy that's bringing your car to you. All these people, are a part of it. But so I really thank you for this opportunity to, to talk with you guys. It's so exciting.
Well, we certainly wish you a safe and wonderful summer.
Thank you.
And again, thanks for joining us and sharing your side of what goes on.
Sure. Well, it's my pleasure. And thank you for the opportunity. And if I can be a help in any way, to any of the individuals, that are here now or that are watching, remotely, I'm always available and always happy to continue to help. But
thank you. Thank you.
My pleasure.
Thank you, Georgine.
Thank you.
Thanks, Bill.
Thank you.
Nice meeting everybody.
Nice to meet you.